So, as an introduction, this is a common complication of pregnancy associated with increased perinatal morbidity and mortality. It has been known, and the definition of intrauterine growth restriction is the fetal weight is below the 10th percentile of gestational age, meaning that when you do an evaluation, do an ultrasound, you realize that the parameters are about less than 10th centile. The problem with this sort of measurement, when you come up with this measurement, you immediately feel that something is wrong with the baby. And that is a mindset lah. Even when you examine the patient pun, when you examine the patient, you do a symphysis fundal height, you try to determine the measurement and so on, you'll realize that it's much smaller. So in your mind, you already think that there's something wrong. Actually, this issue about uterus of smaller than dates is equivalent to a problem pregnancy. It is not, because it is quite challenging, because there is such an entity known as small for gestational age. Alright, so it is quite challenging to differentiate this condition of small for gestational age, where the babies are constitutionally small. Maksudnya, there is no potential pathology. Maksudnya, baby is growing, but the baby is growing at a slower rate compared to the other condition of intrauterine growth restriction, where there is an underlying pathological condition where it's affecting the baby and the baby is not growing very well. So these are two different conditions, and it's very important that we differentiate this condition. So IUGR is actually a subset. Kalau we look at it, IUGR is actually a subset of this whole phenomena of uterus smaller than dates, because it owes to a pathological process inhibiting the fetal growth. So you realize that kalau katakan you have a uterus smaller than dates, about 70% of the time the babies are SGA, small for gestational age. About 30% are intrauterine growth restriction, where there is some form of pathological process is inhibiting the fetal growth. Okay, compared to the constitutionally small baby. So when you talk about intrauterine growth restriction, what are the common causes of intrauterine growth restriction? Actually, if you look at it, this is a textbook description. You can actually divide it into a placental factor, maternal factor, environmental factor, and fetal factor. So one of the important things which we ignore, I would say, are the placental factors. And we don't look at the placenta. Whenever we do a scan, all of us are focused in looking at the baby. True or not? We only concentrate on the baby, we do an ultrasound, we focus on the baby. After that, maybe you look at the Leica volume, that's it. We don't look at the placenta. Placenta will tell you a lot of information. You must look at the anatomical position of the placenta. You must look at actually the description of the placenta itself, how the placenta looks like, whether there's any form of calcification taking place, whether there's any extra cotyledons in the different part of the uterus, and vasculature, whether there's any evidence of vasa previa. So all these things we need to do an evaluation. But sometimes we don't have a proper scan, susah lah sikit. So we need to have a good scan machine. But in a normal, usual scan machine, you can actually do certain things. So some of the factors are placental factors, where you have placental insufficiency. You have maternal factors. Age is one of the other factor, where you have extreme age. Mother is very young, mother is, I would say, senior lah, not older. Some people get offended lah. They have got a tendency to have smaller babies. Okay, sorry. Sometimes IUGR babies. Ethnicity has been proven. The blacks, the American Africans have got higher risk of having IUGR babies. Parity. You have higher parity, there's higher risk. Okay, you have got gravida 12 katakan, there's slightly an increased risk of you having IUGR baby. Height, it has been shown, well, this is I think not authenticated lah. It has been shown that short mothers have got slightly higher incidence. Poor weight gain, short pregnancy interval. This is very important. Short pregnancy interval. Sometimes we talk so much about spacing. Okay, one of the important factor why we actually need to emphasize on spacing is this. You tend to have higher incidence of IUGR, intrauterine growth restriction. Nutrition, the mother doesn't eat properly, the mother is malnourished, then you have a problem. Babies will be small. Infection definitely is one of the factors. Lepas tu, medical conditions, pulmonary, cardiac, renal, liver, autoimmune diseases, and this is something which we always look out for. So whenever a mother presents to us with certain conditions, like for instance cardiac conditions. And the cardiac condition is relatively stable. Sometimes you don't tend to see all these problems. So, but sometimes the cardiac condition, the mother is in actually perhaps in a complicated, she's having a complicated cardiac condition, then you tend to see all this. Because there is placental insufficiency, the babies are not growing very well. Right? So this is something which we need to always have in our back of our mind. We're so focused on the mother. And sometimes we don't see the baby. We also need to actually look at the baby as well. Disease related to pregnancy itself, macam hypertension in pregnancy. Preeclampsia, obviously severe preeclampsia, one of the known complication is actually intrauterine growth restriction. You must always have that behind your mind whenever you do an evaluation, and one of the decisions to deliver will also depend whether there's effect to the fetus or not. Diabetes in pregnancy, okay, most of the time we are always preoccupied with the fact that the babies are big. Diabetes in pregnancy equivalent to macrosomic baby. You also need to recognize that you tend to see about 30% of the fetuses are small, are actually growth restricted, especially the mothers who have got pre-existing diabetes. Anemia in pregnancy is also something which we need to always remember. There's a higher risk of us having an IUGR baby when the mother is chronically anemic. Thrombophilia, environmental factors, it's important, especially those mothers who have got problem with alcohol addiction. Certain medication will give rise to this problem as well. ART, IVF pregnancies, yes, it has been documented. You have high incidence of small babies. Of course, genetic and also chromosome. Chromosome, we'll talk about it afterwards. Chromosome, obviously, when the baby has got chromosomal problem or fetal aneuploidy, the baby doesn't grow very well. So, one of the things you must always remember is genetic factors. So you realize that sometimes when you do this ultrasound, you are looking at the mother, you're doing an ultrasound, you realize the baby is small. You're a bit worried. But when you go back to history, everything looks fine. You're still worried. You keep asking the mother, do you have small babies before, blah, 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 all these things. So mother tells, well, my previous baby is not too bad. The baby was not too small and so on. So you're worried because the baby, every time you scan, the baby grows, but then it's not growing according to the norm. The other thing you must say is call your husband together when you come in next time. Husband will not be short. So if the husband are short, what they call both the couples are small size, there's a tendency that we may have a small baby. So this is what is known as constitutional small baby. So you must always have that behind your mind. Whenever you do a scan, baby is small, make sure both the couple, the husband and wife are there together. Make sure you have a look as well. The types of IUGR classification, I'm sure all these are taught in medical school. You may remember the two types of IUGR, which is a symmetrical type and the asymmetrical type. So the symmetrical type, the difference of these two is the symmetrical type actually will be recognized from the beginning itself, from the early part of pregnancy. It occurs early in gestation. It actually reduces growth of all organ systems, meaning from the beginning, from the early part of pregnancy, the baby is not growing very well, and it has got poorer outcome compared to the asymmetrical growth restriction. Where the growth of the vital organs are maintained. This occurs because the insult actually is in the mid half of pregnancy, especially in the second trimester. What happens is that there is an insult due to certain conditions, for instance, preeclampsia, for instance. Then you will see that the baby is actually splaying off. It becomes, the growth is less than 10 centile. So the vital organs are growing. Alright? How in the expense of other systems, for instance, they call it the sparing effect. The sparing effect, where the brain grows as well as the liver. The brain grows, the heart is actually functioning, and so what will happen is there will be redistribution of blood flow, and this can be easily recognized when you actually have monitoring of fetal growth. It need to be plotted in actually a fetal growth chart. Again, just going through this classification again: symmetrical, asymmetrical. Symmetrical happens during the early part of pregnancy. Is mainly because of congenital infections, genetic disorders. You have a problem, you have a condition, for instance, the baby has got a trisomy. You realize from the beginning itself the baby doesn't grow very well. Or there's a congenital toxoplasma infection, for instance. What will happen is all the cell divisions are impaired, there's decreased number of cell numbers, and it's irreversible condition. You can't do much about it. So all the parts actually doesn't grow very well. The head abdominal circumference may be normal because everything is, all the parts of the baby is affected, and it's poorer prognosis compared to the asymmetrical type, where it's later onset. It's mainly because of uteroplacental insufficiency due to some reason, maternal malnutrition, hypertension, and what happens is that there's impaired cellular hypertrophy compared to the cell division in the symmetrical type, and this decreases the cell size, and it's reversible actually. So as I mentioned to you earlier on, there is this brain sparing effect. So the head abdominal ratio will be increased. So when you plot, you realize that the head abdominal circumference is increasing. So this is one of the so-called parameters we look at, and it's actually a favorable type of IUGR compared to the asymmetrical type. So when a patient comes to you, especially in a primary care setting, okay, patient comes to you in perhaps a clinic kesihatan, you see her and you check her dates. After that, you do an examination. You realize that there's a discrepancy. All right. So remember, always go back to the history. One of the most important thing is the accuracy of dates. Okay, we have got this problem because I've had many times during my clinic. We do detailed ultrasound. The patients are being referred and they call for an appointment. Say it's 22 weeks. We are referring you for detailed scan, blah blah, and so on. So when the patient comes to us, we put the ultrasound, we put the probe. We realize the baby, how come it's so small? I mean, something not right now. But no obvious problem. And then we go back to the history. The patient will actually tell you that the menses which she gave, she wasn't too sure, but she had an earlier menses which she thought she was normal. So the history was not explored. So in that sense, the dates becomes a bit hazy. So she becomes that she's unsure of dates. So no early dating were done for this patient. So when you do a measurement, it corresponds to perhaps about 16 weeks, which tallies with the history. So history taking is so important to determine the dates. That is something which we need to always remember. And of course, relevant other histories like ART, and did she have any early ultrasound? So always remember that if she's unsure of dates, please do an ultrasound as early as possible, because you must remember the principle of 1, 2, 3. So first trimester is 1, second trimester is 2, third trimester is 3, meaning the error margin in first trimester is 1 week. Second trimester is 2 weeks, third trimester is 3 weeks. Always remember that. So if you do a dating scan less than 14 weeks, that is the most accurate timing where we can determine the dates. So the patient is not sure, quickly do an ultrasound. Determine the dates, measure. Okay? If you can get a CRL before 12 weeks, good. Okay, otherwise you can measure the BPD, you can measure the head circumference, AC and female length, and document it, and please write it in the card. What is the re-EDD? I think that is a very important thing which you need to do early enough. And of course, apart from that, the other history which you need to look at to see whether there's any adequate weight gain during pregnancy. Sometimes patients will have this problem of poor weight gain. That can be part of the presentation of IUGR. Patients, you need to explore if there are any other problems. Patient was diagnosed to have preeclampsia and so on. Any other medical conditions, diabetes. We have gone through this, and of course, all this has to be explored. And one other thing is, if there's any evidence, any previous history of small babies, IUGR, okay, it has been shown that it is a repetitive event, okay, and of course, if there's any evidence of stillbirth, also you still can actually have IUGR in conditions of thrombophilia and so on. We can still have small babies, so we need to have all this in our back of our mind. So when you examine the patient, of course, we need to see whether the mother is gaining weight, and you have to ensure that the patient is examined properly. Always remember the discrepancy. The fundal height lacks more than 3 centimeters. 3 centimeters, and the patient is very sure of her dates. This may indicate that there is some element of small baby or IUGR. So you need to do an ultrasound screening. So I'm sure that most of the clinics here already have ultrasound machine. So I'll tell you what are the basic things to do afterwards. So assessment sometimes can be inaccurate, especially when the mother is quite obese, which is quite common in our community. Mother is huge, difficult to palpate. Alright, this is a problem. So we need to depend on ultrasound. So ultrasound pun susah lah. Sometimes with the abdominal ultrasound, it's so difficult to see the images. So if you're still not sure, please refer the patient to us. We will do it for you. Okay. I'm not saying that we have got excellent machines, but at least we will try as much as we can to determine the dates and so on. And of course, kalau mother has got uterine fibroid, also it can affect the presentation, the physical presentation. And examine for other underlying conditions like abnormal placentation, cardiovascular conditions, and so on. So these are some of the things which you need to run through. I'm sure you're good at it. So again, when you do an ultrasound, remember that apart from fetal weight, look at the amniotic fluid. Okay. And accurate dating is important, it's very vital, and dating especially in the first and early second trimester. So you, apart from looking, when I mentioned to you fetal weight, we are looking at different parameters. So you're looking at the head parameters, BPD, head circumference, AC, and also the femur length. So one of the first indicator to tell you that there is actually the baby is affected is the abdominal circumference. Okay. Abdominal circumference is a very sensitive marker for poorly growing baby. Why? Because it will reflect the size of the liver, the abdomen. You're measuring the abdomen because it's soft tissue. The other parameters, like you're measuring the bone, it doesn't really reflect the growth restricted fetus. So always remember that. So when you suspect that there's something is not right, the baby is not growing, give an interval. Perform another scan after about 14 days. Alright? Get the mother to come back and we'll try to do another scan and you just plot it on your fetal growth chart and see how the baby is growing. Right? Especially when the baby you will see that the LICA volume is normal and the parameter measurements is not tallying. Apart from the fetal weight, the other thing which you are looking at is the LICA volume. So when you do a scan, you see the parameters are small, the LICA volume is reduced, that will already give you a clue saying that the baby is maybe perhaps going into IUGR. But if the parameters are small, the LICA volume is normal, then the baby may be constitutionally small or baby may be small for gestational age. There is no pathological process whatsoever. The only thing, the rate of growth is not so good because it may not be due to placental insufficiency. So what are the possibilities when mother comes in with a uterus smaller than dates? Mother comes to you, you do an evaluation, ask history, physical examination, then you realize that the uterus of course is small, and then you do a scan. So at that point you already must have three possibilities in your mind. One is small for gestational age. The second one is there's some problem with the baby itself, either a structural, a chromosomal abnormality, or a fetal infection. Okay, this is the second sort of diagnosis. The third one, which is very common, is placental insufficiency giving rise to IUGR. So these are the three possibilities you must already have in your mind. Yeah. So when you do an ultrasound, when the patient comes to you, you already thinking about that. The baby is looking small and so on. And you do a scan, you estimate the fetal weight less than 10 centile, and you do the abdominal circumference also less than 10 centile. So what do you want to do after that? So you need to do a proper ultrasound just to see whether the fetal anatomy or the placental morphology is normal or not. So you do a detailed scan. Sometimes you want to do a detailed scan. If the baby is already big, then you may not be able to do a proper detailed scan. But you can always look for any abnormalities in the baby, any structural abnormalities, any soft markers. Or look for the placenta as well. I told you just now, placenta is a very important part of ultrasound, obstetric ultrasound. Look at the placenta always. You look at how the placental appearance is looking like, the anatomy as well as the location and so on. Okay, the next thing you can do is, if you have a good machine, is a Doppler study. I'll talk to you about this shortly. Doppler study is something, which will reflect the fetal well-being. And commonly we do a Doppler of the umbilical artery. Why umbilical artery? Because the umbilical artery is within the cord, umbilical cord, and the umbilical cord is originating from the placenta. So the Doppler study of an umbilical artery will reflect the placental function. Okay, remember one of our main cause is placental insufficiency. Yeah? So to diagnose placental insufficiency, one of the key investigation we need to do is a Doppler ultrasound of the umbilical artery. Okay. The other thing is if everything seems to be normal, we might want to suspect it might be infectious condition. We want to do a maternal serology. We can send for torches investigation. But again, depending on the ultrasound findings, if you suspect that there is actually a fetal abnormality, you do a scan, you see some soft markers, and there is actually a mild ventriculomegaly. Or maybe you do a scan, you realize that the kidneys are dilated, the femurs are short. There's some markers, you call it the soft markers. All these are soft markers. And you are suspecting something is not right with the baby. Baby is not growing somehow. So we can offer them a fetal genetic test. We can offer them an amniocentesis to look for the chromosome abnormalities. So, okay, just time check now. So, okay, this is the flow which we can actually go through. So when a patient comes to you, you realize the patient has got a small baby, estimated fetal weight is less than 10 centile. What we do, we can actually do an ultrasound. Okay? We look at ultrasound, we look at the baby, we do an anatomical survey. I'm not asking you to do a detailed anatomical survey, but at least look at the baby, we can do the measurement, and so on. Look at the amniotic fluid. So if there's some element of fetal abnormality or there's increased lipo volume, you suspect something is not right, the lipo volume is increased, then that might be, which is suggestive of some structural problem in the baby, maybe esophageal atresia, or maybe intestinal atresia, duodenal atresia, something like that. The lipo is increased. Then, of course, we go towards maybe a chromosomal or some syndrome or some infection. So polyhydramnios is not a common presentation IUGR, but if you have a structural problem with the baby, yes, the lipo is increased. It commonly is reduced lipo volume. Okay, so if let's say it's all normal, there's normal anatomy, there's normal AFI. Okay, normal AFI normal AFI. Then of course the next thing you do is you do an umbilical artery Doppler. Umbilical artery Doppler is an investigation which we commonly do. Actually, sorry, I need to delete this normal AFI. It's not normal here. It's normal anatomy, but oligohydramnios, meaning the lipo is reduced. So from the assessment here, you realize the baby looks normal, but the lipo is reduced. So that will give you a suspicion. Katakan something may not be right with the baby. Perhaps it's placental insufficiency. The next thing you do is you do umbilical artery Doppler. Remember, I told you this reflects the placental function. So if there is elevated index, then you suspect placental insufficiency. But further, let's say you want to do further Doppler investigations, then we need to do further investigations like middle cerebral artery Doppler and ductus venosus and so on. This perhaps not at your level. This is what we do in the hospital. This is done sometimes to decide whether the baby has got some brain sparing effect and the timing of delivery. So to look at brain sparing effect, we do the middle cerebral artery Doppler. To look for placental insufficiency. If all is normal, Doppler is normal, the lipo appears to be all okay, normal and everything is fine. What we need to do, we need to think about constitutionally small baby or SGA. So we need to serially follow up this patient. We need to do an ultrasound at the interval of every 2 weeks or so. So this is how we do the check. This is how the flow is supposed to be. So remember the 3 conditions: small for gestational age, structurally small baby, chromosomal abnormality, structural abnormality of fetal infection, placental insufficiency. So remember the growth rate in a constitutionally small baby is usually it's a small baby, but everything is normal. Anatomy is normal, amniotic fluid is normal, and for this patient we need to do surveillance, continuous surveillance. There's nothing wrong with the baby really. The baby is only small. You can continue to term and you deliver them at term. But ensure the mother monitors the baby as well. They must put them on fetal tick chart and so on. The fetus has got structural or chromosomal abnormalities. Of course, the baby is small, and you can see some abnormality in the anatomical survey. And as far as the amniotic fluid, it can be variable. Like conditions involving the kidneys, obviously the lipo is much reduced. The timing of delivery depends on the etiology. If placental insufficiency, this is the one which we commonly see, almost about 60 to 70% of the time. The babies are small, the anatomy is still normal, but the lipo volume is significantly reduced. You must always remember that's one of the first things which we pick up, and the surveillance is usually done with Dopplers, which is umbilical artery Doppler, middle cerebral artery Doppler, and sometimes we do a ductus venosus. And the timing of delivery will depend on whether there's any evidence of fetal compromise. So how do you approach? In our setting, one of the most important things when we approach to management is looking at the gestation and the weight of the baby. The baby is too small, we can't do much. The baby is too small in our setting, and we cut off here is usually somewhere around 800. We do a lot of counselling for the parents, okay, and of course we discuss outcomes, and we always involve the neonatologist to decide. But the baby is more than 800, then we can do something about it. So we need to do a proper assessment of fetal well-being, and this will give us a guide to the best time when to deliver. That is why a decision to deliver in IUGR is individualized. It's not much common when should you deliver and so on. So we usually monitor the baby by ultrasound parameters. We do the umbilical artery Doppler assessment. We do an amniotic fluid evaluation regularly. And certain centers, they do biophysical profile. We don't really do it because it's actually too time consuming and so on. And assessment is done every 2 weeks. So I'll just go through quickly because of constraint of time. So umbilical artery Doppler is something which we regularly do, and we actually get this waveform from the free loop of cord near the placental end. It reflects the placental function. Reduction in umbilical artery the reduction in end diastolic flow is the earliest sign of uteroplacental insufficiency. Maksudnya, there is reduction in the phase. They call it the diastolic phase. Right? It goes down. Okay, and you eventually can have an absent end diastolic flow and also reversal. So this is actually the sequence of worsening of the fetal condition. So if it's absent and reverse, perhaps we need to take that quite seriously and decide whether should we deliver or not, because that will guide us towards the timing of delivery. The next thing we do is ductus venosus. Middle cerebral artery and ductus venosus. I won't go into the details. So middle cerebral artery is actually done to see if there's any brain sparing effect. Maksudnya, the blood flow to the baby is sort of shunted to the brain, and you realize the waveforms are different. Also, another guide is a ductus venosus. This is actually a small portion where there is a communication of the umbilical vein to the IVC. So the ductus venosus is a very sensitive marker to tell us whether the baby is compromised. So these are the things we do, and also of course the amniotic evaluation. We do the measurement. We can either use amniotic fluid index or deepest vertical pool. So when you do amniotic fluid index, you measure the 4 pools, and if it's oligohydramnios, it's less than 5. Always remember, oligohydramnios less than 5. Or you can do a deepest vertical pool. You have difficulty in getting the pools 4 quadrant. You do a 1 quadrant and you measure. If it's less than 2 cm, also will tell you that this is oligohydramnios. I won't go into the details of this because we don't do this biophysical profile. Some centers are doing this. You're looking at all the different variables, movements, body movements, tone, heart rate, and so on. Okay, this is an important slide just to tell you the fetal response. The fetal response to how the fetal response to deprivation of oxygen. Okay, chronic deprivation, compensation, and decompensation. So when there is decreased oxygenation to the fetus, the baby has got hypoxia, and worsens, the baby becomes asphyxiated. So what happens intrauterine? So the first thing which happens is of course the decreased fetal growth at this point. Then later there is fetal polycythemia, there is fluid redistribution. I told you right, there is redistribution to the brain and so on. This is when we pick up with the Doppler. The next thing is the umbilical artery Doppler index. So at this point you can already see that there are some changes. And you can see that there is already a MCA Doppler giving rise to some lower MCA Doppler giving a brain sparing effect. And at this point, the baby is becoming slightly worsened. There's decreased amniotic fluid, decreased activity. So we need to recognize at this point and deliver. If you don't do anything at this point, then they're going to have a problem. Then eventually, the baby will have umbilical artery absent and diastolic flow. There's loss of fetal movement, fetal heart variability, reverse end diastolic flow. Ductus venosus will show A wave reversal, and of course, multi-system failure in the fetus and death. So we need to pick up at this point and make sure we deliver the baby. Okay, at this point we don't catch the baby, that's it. The baby will eventually die. This is what happens sometimes. We do a CTG, we ignore the CTG findings. So, okay, I'm short of time. quickly I'll go through what are the parameters, what we use to measure. We use Doppler, we can use fetal heart rate, or in other words we use CTG, we can use amniotic fluid alone, just also to see, but we don't, not to say we depend on it alone, but we use it in combination to decide on our timing of delivery and biophysical profile. But biophysical profile, we don't really use it. So you realize that early signs can be picked up by usually the normal umbilical artery Doppler is normal. Then later it becomes elevated. Yeah, and the middle cerebral artery is normal. And at this point, one of the early signs, there is already evidence of brain sparing. Normal umbilical, normal ductus venosus. Later, it's a late sign where you become all the abnormal findings. And an umbilical vein also will have late signs of pulsatile flow. So these are some of the Doppler changes which occurs at different phases. And of course, this is CTG. You realize that there's different changes in the CTG which takes place. Then amniotic fluid, you already show signs of decline and hydramnios and biophysical profile. So these are the four important things which you always do. Okay, quickly, approach of management. When you have a diagnosis, we do an evaluation of parameters. We also look at amniotic fluid and also together with Doppler. So remember, here in the hospital, this is how we approach the patient. We always look at the parameters. Baby is small, we do an amniotic fluid and at the same time do a Doppler. Sometimes we decide on the middle cerebral and ductus venosus. And when there's evidence to show there is fetal compromise, we need to importantly look at the weight and also the gestational weight, and we consult the neonatologist. Can we deliver or not? Okay, that's why you have to be very nice to the neonatologist. And if possible, if you are still single, get married to a pediatrician, because it's so important that we need to be nice to them. Sometimes they're quite nasty to us, but we are sorry. I hope nobody's here. So we make sure that we counsel the parents as well. Administer medicine sulfate for fetal neuroprotection. So that's important, and also steroids. And once ICU is available, we deliver the baby. Okay, this is our approach. Because all the complications of the baby can happen, including asphyxia. But there's no fetal compromise. We monitor closely. Weekly umbilical artery Doppler. We do an amniotic fluid assessment. Every 2 weeks we see them for growth assessment, and then we decide on the timing of delivery after consulting a neonatologist and telling the parents. Okay, this case scenario I don't think I'll go through because of the interest of time. I'll skip this. And the key points: if you suspect something is not right, baby is small, please do an evaluation early. Okay, and fetal surveillance should be carried out. You should not ignore this sign. It's very important. Timing of delivery is individualized. Counseling of parents, always remember, is very, very important because sometimes they don't know what to expect. Suddenly you tell them, certain things. Sometimes when the baby comes out asphyxiated, then it's difficult to counsel them after that. Thank you very much for your attention.